So good morning, respected faculty and dear delegates. We welcome you for this session of pediatric cardiology. I welcome Dr. Nageshwar Koneti, sir, who is the speaker today, and I request Dr. Shamina to please introduce the session and request Dr. Neeraj to begin.
Hello, good morning all. On behalf of Indian Academy of Pediatrics, Delhi State, a warm welcome to all, especially our today's speaker and Dr. Rao regarding the common topics about the hypertension, and our chairperson, Dr. Salu and Dr. Kanav. I would like to thanks to our team behind the curtain doing the hard work to make the successful of this program. Dr. Neeraj and Dr. Dul and their team, they are doing the very hard work, and definitely we made this program one of the successful event as a master classes of pediatric cardiology. So thanks to all my IFP office bearers, my IFP office staffs, and Dr. Neeraj Agrawal and their team to make this program to successful. Thanks to all. Over to Dr. Neeraj.
Thank you, sir. Thank you, IIP program. And it has been a wonderful series, last class today. So we have respected chairpersons today. Dr. Shalu, sir, he's a professor and head of department pediatrics, and he's in charge of ICU in Kalavati Saran Children's Hospital, Lady Harding Medical College. Dr. Shalu, sir, is well known in Delhi NCR and in India. He has been doing a lot of practice and training people in dentistry care, especially in north part of India. But he's a highly respected person. Dr. Shalu, sir, good morning, and your comments are welcome for this program, sir, today's program.
Yeah, thank you, Dr. Neeraj. And it's really a great pleasure to be on this platform among some of this August gathering. And I would be really looking forward to listen from a very eminent person like Dr. Nageshwar, who has done a very great job. I think I am really proud of him, who has brought something laurels to maybe India as per se.
Thank you, sir. And thank you, sir. Dr. Kanav is the second chairperson. Dr. Kanav is very expert in pediatric nephrology, well known in North India, in NCR. A lot of people know him that he is doing interventional nephrology work in pediatrics. He is doing CRT in Gangaram for years. He has been doing it. And, he has been recipient of multiple awards starting from the early career of rising talent to established talent now. He is our man to go in Gangaram for any pediatric nephrology work. We need him in pediatric cardiac ICU, in pediatric ICU, in OPD, because systemic hypertension, I believe is more of nephrology prerogative than cardiology prerogative. Lot of patients need nephro consultations rather than cardiac. But let's see. Today, Dr. Kanav, good morning.
Yeah, good morning.
Please some words of wisdom from you today.
So, good morning to all of you. So basically, as we all know, that majority in children, we have a secondary hypertension as a major cause rather than a primary essential hypertension being the major cause of hypertension. So it's mandatory that we work out the patient and find out whether it's a nephrology, or you can say the kidneys are the culprit for hypertension, or is the heart. And majority of the time, as Dr. Neeraj said, 60% of the time it's the kidneys who are at fault rather than the heart. So let's see. We'll go for the presentation and then we'll have the comments.
Thank you, Dr. Khanna, for joining us. Now it's our time to listen to Dr. Nageshwar Rao. Nageshwar Rao, sir, is today's speaker. He's a chief pediatric cardiologist in Rainbow Hospital, Hyderabad, and he has done DM cardiology and fellowship pediatric cardiology from Sydney. But it's a very small introduction. He has wonderful thing done in India. That is, he has introduced his own his own device closure. It's called Konar MF device closure. It's a multifunctional occluder. We all use it. This is first device from India which has been US patented, and he has single-handedly managed this project. So this device can be used for all the closures like fistula closure, device closure, ASD, VSD, PDA, and beyond this. I'm happy to see him today, and he could accept our invite to have a talk. In a pediatric cardiology community, he's regarded as a father figure. People ask for his opinions. Even I call him sometimes that what should I do in my case? So he's always supportive. He's a father figure to us, he's a teacher to us. We all respect him, highly respected person. And, I'm really obliged to have him on the dais today. Nageshwar sir, good morning, and please, can you start the session today?
Thank you very much for your very kind introduction. I think you are very much lean towards me. Probably there are many people in this country, their contributions are really very much respected. Being a pediatric cardiologist, our contribution to our field is probably somewhat significant at this point of time. And we are all working as a team. I always feel that we work very closely with the pediatricians in our city. Coming to the present topic, I thank Dr. Sham, Dr. Ajay Kumar Gupta, Dr. Kanwa, all the dignitaries, including Dr. Shalu Gupta. So this is the one area extensive research has been done, and also the definitions, the criteria, the guidelines keep on changing over the period of time. However, the last guidelines from American Academy of Pediatrics came in 2017, and European Society of Cardiology also in 2022 with the more or less same alignment. So the definition of pediatric hypertension is actually subcategorized into two groups, that is lesser than 13 years of age group by age, sex and height percentage, and second one is more than 13 years, where you can call it as adolescent group. They are close to the adult, where they achieved the normal systemic vascular resistance and normal blood pressure. Therefore, less than 13 years of age group, for the age, sex and height percentile, the normal is lesser than 90 percentile, elevated is 90 to 95th percentile. Then stage 1, you have to add plus 12 millimeters of mercury. Anything more than 95 percentile plus 12 millimeter or more than 140 by 90 millimeters of mercury, it is stage 2, very important. They need immediate attention. Similarly, more than 13 years of age group, I prefer the guideline rather than the regular practice, because several of these children will have white coat hypertension. I will tell you about that. So when it is elevated, it should be more than 120 by more than 80 millimeter. Stage 1, 130 to 139, whereas stage 2 is 140 by 90. Isolated diastolic hypertension is somewhat little bit rare in children, but you see systolic hypertension, probably essentially it is due to anxiety and other aspects. If you look at the prevalence of hypertension is 15 to 90% in boys, whereas girls it is a little bit less during the childhood, whereas the prevalence is slightly higher during adolescent group, probably because of the hormonal changes. But the category overall, it appears that girls have got little bit lesser. The latest studies showed that in cumulative population, the overall it's around 2.5 to 3.5% among the children are regular who are undergoing the health education and health evaluation. There's a study which people actually tracked these patients and found that there is high incidence of hypertension in adulthood. However, if you see a child of diabetes, obesity, sleep disturbance, or the upper airway obstruction, these are the patients that are more prone for the hypertension, and we should really evaluate them every year as per the healthy trial, that is a school-based trial conducted in multi-center. So the pediatric hypertension to diagnose, you should do at least 3 screenings. This is very important in that particular period, because most of the children, they are afraid of white coat. In our hospital, we removed the white coat. we removed the mercury manometers, which is now as per the OSHA guidelines, we can't use the mercury manometer. For the regular screening method, you can use oscillatory electrical device, because at one particular time, all children should have the blood pressure recorded. So the people who are coming to the clinic or institute or nursing home should have at least oscillatory electrical device method. And if there is any kind of deviation, then you should confirm it at least 3 times, and then do the aneroid sigmometer if it is positive even in the first instance. So the aneroid sphygmomanometer, there are 2 types, mercury, non-mercury, and mercury sphygmomanometer. Now mercury one is removed. That's why you have aneroid sphygmomanometer. We use this one in our hospital. We keep mercury for the cath lab calibration. So if there is direct estimation of blood pressure is high, here there is no need for calibration, whereas oscillatory method, you need to have the calibration. So how to actually measure? This is going to be very important. These are all cuffs photo I have taken couple of weeks back for the sake of talk. You have infant, you have neonatal, infantile, early childhood, late childhood, and then adolescent. The cuff length should encircle at least 80 to 100% here. The bladder width, this is the bladder where the inflation cuff will be there, it should be 40% of the circumference. And the marker should be preferably on the brachial artery. So these are all the important steps, because I don't see any of the physician in a busy practice of seeing more than 30 patients. It is practically possible to check the BP for every patient. So therefore, you need to standardize your equipment and your department with a nurse who is trained in this and should check. In our department, we have 2 nurses and 3 fellows. We all check for all patients who are coming at least in the first visit, and then subsequently we confirm that. So the oscillatory method, the major disadvantage is it may spuriously give mean blood pressure higher, and you may get systolic low and diastolic low sometimes because of the cough which is going to be inflated for long time. So therefore, once the systolic blood pressure or mean blood pressure is significantly higher, then it's mandatory to check the sphygmomanometer, preferably aneroid, and you have the bladder should be inflated more than 120 millimeters of mercury. Then you auscultate, find the Korsakoff signs, appearance, and then complete disappearance. You have to check it for the diastole. However, the BP chart should be pasted in the clinic. We keep a chart there so that you will get the idea of every age group. You can follow the nomograms, absolutely percentiles, but absolute values are very interesting, very essential. It is easy for the nurse to identify or fellow to identify the patient is having hypertension or high blood pressure at that particular time. It's very important, especially in infants and children who are crying, to sedate them and check it. And for the neonatal systemic hypertension, most of the times it's measured in the nurseries, where the hypertension in the preterms who are following is very important. Here you go by predominantly mean arterial pressure rather than systolic here. So in neonatal systemic hypertension, very essential to know the even mean arterial pressure, whether you can label that as a hypertension or not based on the gestational age. So once you diagnose hypertension, at least in 3 occasions, then you are going to label them as elevated blood pressure or stage 1 hypertension or white coat hypertension, or if there is associated with high risk morbidities like any of the chronic kidney disease or obesity or family history of hypertension or any of the genetic disorders. So in this setting, we should do ambulatory BP monitoring. So this is very essential. All centers, this is one of the case example of a child where you connect the blood pressure based on the arm circumference. So you have only 2 cups here. That is a major disadvantage of ambulatory BP. You have 2 cups. Sometimes we try to put it 5 years, less than 3 years, but practically it is not possible. But it is useful, definitely more than 7 years of age group. You connect this and give the monitoring mission. It's keep on inflating every half an hour, and you will get the trends here. So assessment of these ambulatory blood pressure trends are very essential, because you see this pattern in the morning and early morning. As per the circadian rhythm, it will be totally dissociated. So if you look at the healthy individual, there will be morning surge because of the catecholamine increase and growth hormone increase, and gradually in the night there will be dip. Whereas the nocturnal animals, the reverse is true. You will have daytime it is a dipper, and nocturnally there will be surge. So in case of children with hypertension, more prone for hypertension, there will be morning unusual surge, and also the night dipper may not be that significant. There will be elevation. So you can see here the morning surge is there, even in the night, which is not significantly falling in this particular patient. So what will happen during sleep? The sympathetic system will be withdrawn, parasympathetic activity will be more, so that there will be bradycardia, there will be fall in systolic and mean blood pressure, the SVR also will be fallen. So if there is a sleep disorder, if there is a genetically prone hypertension, and or if there is apnea during sleep, the upper airway obstruction, so these patients may get hypoxia, hypercarbemia, and increased inflammatory oxidative stress, or during the REM sleep itself. In REM sleep, you will awake. NARM sleep itself, the sympathetic activity will be more. There will be vasoconstriction and hypertension. That's why the ambulatory BP is going to be very, very important, and assessed during what is happening during NREM sleep, REM sleep, and during morning awake period, and nocturnal dip is there or not, you should assess. Based on that, you can have the classification of a completely normal or pre-hypertensive. If there is a increase in the early morning and a good significant fall in the night, or if there is a continuously which is present, then you can label it as a hypertension. You need to actually optimize the treatment. So the ambulatory BP is going to be useful to diagnose the condition, and also to observe the treatment response. So I don't have our data. Probably we'll come back with the data. We have done more than 180 patients so far, but the hypertension, as which is actually prevalence is more or less the same, but we have many of the renal parenchymal disorders which we actually connected to see the treatment response. If you look at the pathophysiology of the systemic hypertension, the environmental factors and the genetic factors. So I'm talking about the hypertension, which is a primary, not secondary. So here the genetic influence is defects in the renal sodium hemostasis, uh, or inadequate sodium excretion. There will be sodium retention and increased plasma and extracellular fluid volume that increases the your natriuretic hormone, which actually causes increased vascular activity. So this extravascular fluid, whatever which is getting increased, which increases cardiac output. Now you understood that diuretics play a major role in this particular setting to reduce the volume. So if you give diuretics here, your plasma volume will come down, your extracellular fluid volume will come down, so that even the increased cardiac output, which will cause the shear stress in the distal vasculature, in the kidneys, peripheries, and also in the brain, all this will come down. Whereas here, the defects in the environment due to various stress or environmental factors, whatever it is, which is causing defect in the vascular smooth muscle growth and structure, increases vascular wall thickness and increases peripheral resistance, that is SVR will be increased, so that increased vascular reactivity and hypertension. Here various drugs play a major role. A central acting medications will play, or beta blockers will play, or AC inhibitors will play. Those are the very important medications in children. So various mechanisms and various the factors like genetic, inflammation, environmental factors, obesity, and fluid overload, high salt intake, all this will cause damage to the target organs of the aorta, aortic distal vessels, myocardium, which causes hypertrophy and eventually ventricular dysfunction, and vasoconstriction in the brain peripheries and renal. So and also retina here. All this will cause a serious impact in the total body. So in order to avoid the target organ damage, its early recognition and treatment is very important. Otherwise, vascular remodeling over the period of time will cause a hypertrophy, distal vascular constriction, and uh, renovascular hypertension. Again, the renal problem is going to happen because of the renin angiotensin aldosterone system also will be activated significantly. Then aorta will become more and more stiff. The refractoriness of the hypertension is going to be inevitable, and persistent of SVR is going to be inevitable over the period of time. Therefore, systemic hypertension in children are classified into predominantly three categories. One is a transient hypertension, secondary hypertension, primary or idiopathic. The transient hypertension you regularly see in all departments. You take neurology, any patient with encephalitis, or you take infectious disease, any kind of viral infection, dengue fever, COVID, or even acute post-streptococcal glomerulonephritis, all these are going to be transient, whereas the secondary predominantly either it is vascular or renal. Primary, you won't find any cause. It may be purely genetic or hereditary or familial. So if you look at the infectious causes for the transient hypertension, commonest is the PSGN, and we all know that how to actually manage this. The commonest medications which we give, diuretics. I will probably discuss about the treatment part later on, but I want to just tell you the conditions which produce the transient hypertension, PSGN, urinary tract infection, some cases of Kawasaki disease, some cases of even viral myocarditis, which we see, and especially dengue fever. There are two types: the hypertension with bradycardia type and shock presentation, any kind of encephalitis and meningitis. COVID period, we used to see several cases with hypertension. Recovery phase of even sepsis, you will see that. Whereas the secondary causes or important causes are predominantly renal artery thrombosis, congenital renal abnormalities, coarctation of aorta are important causes. That is in neonates. Whereas in children and adolescents, again renal causes, coarctation. I will show you some of the examples. It will be interesting. The distal part, I did not keep those cases in the beginning. Endocrine causes, and whereas the systemic causes, renal causes like glomerulonephritis, reflux nephropathy, renal artery stenosis, polycystic kidney disease, end-stage renal artery, coarctation of aorta, Takai's arthritis, pheochromocytoma, hyperthyroidism, Cushing's syndrome, and recently we had a case of Guillain-Barré syndrome. She was having a hypertension and a hypotension because of the dysregulation of the autonomic nervous system. And patients who are on steroids will have the hypertension. Once you wean off the steroids, usually the hypertension will fall. Very rarely they will have refractoriness. then neurofibromatosis, and finally the primary hypertension. The treatable causes, this is what very important, what we need to look at. This is where we work together with the nephrologist, and we actually have a combined patient pool to treat by the nephrologist and the cardiologist, but we did not start any kind of a clinic so far. Probably with this talk, I thought we should have a combined hypertension clinic at least once in a month. So renal parenchymal disease, renovascular hypertension, endocrine disorders, cardiovascular causes, drugs, neurological, and other anxiety related ones. So the secondary causes contribute close to 40 to 70%. So that means your most of the systemic hypertension in children, they need very aggressive evaluation. The idiopathic or primary is going to be very, very less, that is lesser than 10%. Even then, we found actually during the follow-up period, when you aggressively investigate, I'll show you one of the case example, you may find some other abnormality. In the renal parenchymal or secondary causes, renovascular hypertension itself is 12 to 13%. Whereas lesser than 6 years, the renal causes are much higher. It can be focal stenosis, vascular malformation, or stenotic lesion, or thrombotic complication. All will be seen. We have seen all cases of, even including the aneurysm of the renal artery, fistula we have seen, and you will have the renovascular hypertension due to peripheral segmental stenosis, and sometimes aorta arteritis here extending into the renal arteries, and especially in neonates, you will see the thrombus, which is saddleback thrombus originating from the ductus arteriosus. In case of ductus arteriosus aneurysm, you will see here occluding the both the renals. So the evaluation includes, we should properly take a prenatal and perinatal history, maternal hypertensive disorders, birth weight, preterm, the nutritional history, what is the child's physical activity, how many hours in a week spending for the isotonic exercise, especially 12 hours should be there per week. What is the psychosocial stress of the child, any parental separation, depression, peer group problem, or anxiety due to adolescent age group, or homework and education related anxiety, especially after some of the schools there is no, we studied actually in Hyderabad, there are 80% of the schools, they don't have playground, and most of the educated family, they prefer to put their children in those schools for the education. Whereas in the rural area, 80% of the schools are having a playground, but lack of staff and infrastructure in the schools, they don't prefer to put them in the schools. So there is a serious paradox in this society. Lack of physical activity, lack of playgrounds is one of the important psychosocial and physical cause for the hypertension in children, especially Tanner's stage 2 and 3 adolescent age group. If there is additional family history or family history of anxiety, parental separation, this is going to be much worse. So in these children, the physical examination should be done. However, you may not get really answers, but a high degree of clinical suspicion should be there to rule out secondary causes. So vitals, you should check for the tachycardia to rule out anxiety, any kind of BP difference or pulse abnormality to check the aorta arteritis. Eyes, you should see the proptosis, retinal changes of the hypertension, any kind of web neck in case of girls to see Turner syndrome, or Erifflin faces. This is a congenital Williams syndrome where the arteriopathy, you will see hypercalcemia is present in this age group, and also thyrotoxicosis. I'll show you one of the case, and obesity, neurofibromatosis, chest deformity, and abdomen for palpation of the polycystic kidneys or any mass of pheochromocytoma, genital ambiguity to see any endocrine abnormalities. All these things are going to be useful. This is the clear-cut chart which shows that physical examination has got a serious limitation. All this will give indirect clues to the etiological diagnosis. So in step one, what you have to do is first you confirm the diagnosis. Do 3 occasions. Remove the white coat hypertension. If there is any kind of suspicion by oscillometer, then make sure the child is comfortable and doctor should confirm the hypertension is there or not. Second step is rule out all common causes which causes the transient hypertension or renal causes for the hypertension. The third stage is you investigate very aggressively for the secondary causes, and the fourth stage you are going to do advanced imaging, that is the CT angiogram, conventional angiogram, combined clinic with nephrologist and endocrinologist, or vice versa. So after taking history, as a first stage, diagnostic tools include a complete blood picture, serum creatinine, urine routine examination to rule out any of the renal causes or urinary tract infection, or renal ultrasound to see the polycystic kidneys or parenchymal disease, or renal Doppler, maybe that is second level of investigation, the ECG, chest X-ray, echocardiogram, and are going to be useful. I'll tell you each and everything has got its own problems. The second test is going to be a level 2 urine analysis, which includes a protein and ratio, then catecholamines for 24 hours urine to check the pheochromocytoma. Porphyria cannot be diagnosed in single point. It has to be diagnosed in multiple setting. And CT angiogram for renal artery stenosis. We found that renal Doppler in children is useful as a screening, but the sensitivity is not very high. Even you can miss, experienced radiologist can miss that because of the segmental renal artery stenosis. They can't diagnose. That's the reason in a refractory cases where there is a suspicion, we should prefer to do CT scan or MRI scan for the renal arteries. And finally, you may do renal angiogram. So you can see that the ECG has got a specificity but low sensitivity for LVH. Just because there is a LVH, you cannot tell that there is LVH, because the thin individual, thin boys, you can have LVH. Here you can see the echocardiogram is showing that there is a significant left ventricular hypertrophy there. Left ventricular hypertrophy, we calculate the LV mass. If the LV mass is more than 52 grams per meter square in the small age, that is lesser than 6 years, or 115 grams per body surface area when they reach to the adult in case of boys, or 95 grams in case of girls, you will consider that as LVH. LV wall thickness more than 1.4 centimeter at any given point is going to be an important echocardiographic sign to tell that there is a left ventricular hypertrophy. The other parameters to rule out coarctation of aorta, lab test, drug screening, lipid profile, and see the renal artery and sleep studies. So once you complete the diagnosis, is this child is having hypertension or not is the question. Once you label that, I am going to tell that algorithm maybe after completion this, because I want to actually show this before we go to conventional management for the stabilized hypertension. See, several of these times we get the children with a hypertensive crisis, especially in the pediatric nursing homes or institute, where the child comes with comatose state, either neurogenic problem or infectious disease problem or renal related problem. These are the 3 important etiological conditions where they come. Maybe fourth one is aorta arthritis. I would consider that also in the renal related problem. So once you see the hypertensive child, crisis, that is definition wise, there is a raised blood pressure, because sometimes the hypertension crisis may not go more than 95 because of the LV dysfunction or some medication which is already given. Any kind of semi-comatose or semi-conscious or unconscious patient comes with hypertension, you have to rule out very quickly other causes, and probably you should consider very quickly hypertensive crisis. If it is there, then see the target organ damage like kidneys, brain, and then heart LV function. So if everything is good, start the treatment. First, preferably, you can see the general condition of the patient. If it is a good ventricular function, a good renal function, sodium nitroprusside is going to be the drug of choice. When you are giving a sodium nitroprusside, you should have arterial line, and you should cover the medication with the aluminum foil or block tubing is important. Otherwise, the light itself will cause and produce the toxins in this, and usually 0.3 to 8 microgram per kilogram per minute should be given. The most safer medication, if you are not comfortable, if there is a ventricular dysfunction, renal problem is there, anything, any given time, you can start the nitroglycerin. And nitroglycerin, the main problem is it increases the heart rate. In the presence of ventricular dysfunction, nitroglycerin is sometimes may be useful, sometimes may not be useful based on the clinical scenario, but usual dose is 0.5 to 5 micrograms per kilogram per minute, and which actually reduces both the preload, whereas the nitroprusside is a pure arterial dilator. Then diuretics usage, then you have to give the IV labetalol if there is ventricular function is good. Lot of intensive care people, they use the IV labetalol. If there is bradycardia, we generally avoid, even though which has got a predominant alpha receptor blocker, there will be reduction in the heart rate. So hydrogen is oral, but in a rural practice, somebody is living in a very periphery, you don't have any medication, immediately sublingual nifedipine is going to be very, very important. If you give sublingual nifedipine, the blood pressure control is going to be very fast. So this is what we do in most of the centers. You give either sublingual nifedipine, or start, if you are in ICU, either sodium nitroprusside, nitroglycerin, labetalol, apart from diuretics. So as a general principle, for the stabilized hypertension diagnosed one, start with monotherapy unless blood pressure is high. That is the guidelines which is say, but generally what we are practicing in young children, we start with the monotherapy, preferably calcium channel blocker. In case of adolescents or grown-up children, a diuretic plus calcium channel blocker sometimes useful to reduce the increased plasma volume. And then adjust the medications every 2 to 4 weeks based on the BP response. And it's important to look for the renal function and electrolytes when you are giving the diuretics, because they tend to develop the electrolyte disturbance. And very important to modify the lifestyle, especially salt restriction, activity, the physical activity. So the principles are: reduce the volume overload by giving the diuretics, and improve the renal functions or renovascular by giving the AC inhibitors or ARBs. Or if there is any kind of ventricular dysfunction, it is better to avoid calcium channel blockers and beta blockers. If there is a good ventricular function and a grown-up child, you prefer either beta blocker or calcium channel blocker. Always you should remember both have got a negative inotropic effect. Whereas central acting medications, in case of renovascular disease or in case of refractory hypertension, iotarditis are indicated. Choosing an antihypertensive medication based on etiology is going to be very important. I feel this slide is going to be very educative or very important. Any postgraduates who are seeing the attending this, they should note down that commonest renal parenchymal disorders, we should consult the nephrologist. If it is no contraindication, if there is no bilateral renovascular hypertension, renal artery stenosis, you are safe to give AC inhibitors or angiotensin converting enzymes or ARBs. Whereas renovascular hypertension, which is present, and if there is any kind of dual therapy is required, or while waiting for the evaluation, you can give calcium channel blockers as a monotherapy, or if there is no contraindication, you can give the AC inhibitors. If there is obesity and hypertension, sedentary activity, then probably you should think about either beta blocker or calcium channel blockers if the heart function is good. In case of coarctation of aorta, even though recommendations are alpha blockers, we always prefer to give beta blockers because the response is going to be very good. Try to avoid AC inhibitors, ARBs in that situation. Whereas hyperadrenemic states, if they present with shock or hypertensive crisis, as I told you, sodium nitroprusside, labetalol, or sublingual sarbitrate or nitroglycerin should be given. Beta blockers are useful, whereas post-operative conditions, you can give spironolactone in most of the conditions along with other medication. These are all the drug chart which is available freely in the net. I don't want to tell you all those things, but what is preferred? We prefer as a monotherapy, amlodipine, especially in grown-up kids more than 6 years. The dose start with 2.5 milligram. It is very difficult to actually break the tablet because suspensions are not available and make it to that body surface area. Therefore, we make it very close to that denominator. So 10 milligram you can cut into 5 milligram and it can cut into 2.5 if there is a double score. So amlodipine as a monotherapy to begin with in mild hypertension, whereas nifedipine is going to be useful in all age groups. Believe me, you can start from preterm baby to adult. Nifedipine, you can give that either sublingually or orally. We prefer any acute hypertensive crisis or transient hypertension, nifedipine we give, but the major disadvantage is very short half-life of this. It works for 4 to 6 hours, so repeated doses are needed. Whereas in case of aorta arthritis, a long-acting nifedipine is going to be a very good medication as a combination with other medication. AC inhibitors, unfortunately now captopril is not available. That is the major problem to all of us, because earlier captopril was there, we were giving every 6th hourly or 8th hourly. Now you are going to give the enalapril. The major disadvantage with enalapril is serum creatinine. They develop renal failure, non-alcoholic renal failure, and then finally terminate into renal failure. That's why whenever you are giving renal enalapril in case of lesser than 1 year, it's very important to check the serum creatinine. Rather than milligrams, millimoles is going to be useful because you can see the escalation of increase of rise of serum creatinine very rapidly. So in our department, we give enalapril in grown-up kids more than 1 year. Less than 1 year, we are not preferring. We give hydrogen, which is a pure arteriodilator. Whereas lisinopril, we prefer more than enalapril because the lisinopril, the activity, the pharmacological activity, sustainability of the control of hypertension is much more superior compared to the enalapril. We are not preferring other AC inhibitors. Whereas ARBs, losartan is a very good medication, believe me, and we start losartan for most of the patients. Of course, we prefer first the AC inhibitors over ARBs only if there is a cough, if there is asthma, winter cough. Those patients we stop lisinopril or enalapril, then we give either losartan. Very rarely, if there is a ventricular dysfunction associated with that, then valsartan is going to be useful along with the diuretics. Beta blockers, I like beta blockers in most of the anxiety children or adolescent group where the left ventricular hypertrophy is there. Whenever there is a left ventricular hypertrophy, AC inhibitors or beta blockers are going to be useful beta blockers, to begin with, it is a good idea to start with the propanol, and then you can switch over to the metoprolol, which is the long-acting medication. So we don't use other medications like atenolol and all, which is going to cause more fatigue in children. Therefore, we prefer to avoid that. So as I told you, preferred antihypertensive agents based on etiology. AC inhibitors are good for the renal parenchymal disease, glomerulonephritis, diabetic nephropathy, proteinuric chronic kidney disease. As consult, you please consult with a nephrologist, and they have much more experience than cardiologist in this particular area. ARBs, renovascular hypertension, intolerance to AC inhibitors, like I told you, cough, calcium channel blockers in case of isolated systolic hypertension as a monotherapy, and I generally avoid in coarctation of aorta, even though some guidelines they propose that. Diuretics, important. Beta blockers in case of hypertensive states or in case of anxiety children. Central acting in case of resistant hypertension, aorta arteritis are going to be useful. Let us see a couple of case examples. This is my second part. I'll show you that. This is a 12 years old child. Can we take questions now? I think I will complete this. Is it okay, Neeraj?
Yes, sir. Yes, sir. Yes, sir.
So you can see this is a 12 years old boy with acute heart failure. I'll just put photos also. Yeah, acute heart failure. And you can see the ECG, there is high voltages there, whereas the left ventricular hypertrophy is seen. So actually that child was getting treatment for heart failure. One of the postgraduate noticed in government hospital called Nilofar Hospital in Hyderabad, very good hospital. It's a teaching institute. They noticed that there is a LVH by ECG, and they asked us to do the echocardiogram. We did the echocardiogram, showed LVH. Then we asked what is the blood parameters. Blood pressure was 132/90, ESR was 90. So thorough evaluation was done, and you can see that the abdominal thoracic aorta, there is a severe stenosis. This is a this is aorta arteritis secondary to inflammatory disease. So in this particular child, due to aorta arteritis, significant aorta stenosis, here you can see the CT scan, and also the subclavian artery is stenosed. He developed severe hypertension and ventricular dysfunction. So the treatment is different. Initially, you give the medical management for the aorta arteritis and control the hypertension. Then you go whatever the best treatment, either balloon or whatever the stenting, or very rarely even surgically. So I will show you some of the cases. This is case 2, a 3-year-old girl admitted with shortness of breath, severe respiratory distress. Child was very sick actually. There was a gallop, referred as a myocarditis. We saw that the pulse was very weak and the BP was 80/46. If you look at the X-ray, you all agree that there is a cardiomegaly, there is pulmonary edema, batwing appearance is here. So the LV function also is less. So you can see that we started medications immediately, and LV dysfunction is improved to moderate degree. The LVEF, you can see here, LVEF is around 25%, 25 to 30. So we managed as per the protocol, given the diuretics, and started milrinone, and slowly the pulmonary edema disappeared. You can see improved. I won't say disappeared because you can see the left bronchus still air bronchogram is present. This overexposed X-ray. So the investigation did not reveal anything at this point of time. Creatinine is normal, ESR is normal, everything. Then after 2 days, child started developing having hypertension. You can see the blood pressure range for that age group above 120 millimeters of mercury in systolic, and diastolic above 80 millimeters of mercury. Then what next? Day 3, blood pressure was 130/82. Then we started evaluating. The renal Doppler was advised. the renal Doppler gave us some clue that there was some turbulence in the renal artery. So after that, we consulted nephrologist. He said very safe to go for the angiogram. You can see that angiogram. I'll go back. So this is the, you can see the renal artery, which is critically stenosis. Sorry for that. So the renal artery here you can see, which is critically stenosis, very, very small amount going. That is the still picture on the other side. Then we actually thought of doing the balloon dilatation, but child is a little bit grown up. The other side renal artery is totally blocked, and it was very essential to treat this, salvage this baby properly. That's why we had to stent that. And post procedure, the BP was improved. However, child was in multiple medication. 2 medications we started the child on diuretics and also beta blockers, and after that improved very well. This is another interesting case. A 12 years old girl presented with a shortness of breath, easy fatigability and cough. Clinically, there was unequal pulses. Our postgraduate detected that right upper limb pulse was not palpable at all. Then blood pressure palpable, then with great difficulty, the blood pressure given, but it was spuriously coming, very oscillatory method, very wrongly was coming. Then we checked it, the lower limb BP was very high. There was a significant, lower limb BP was significantly high, but there was a significant disparity was seen. If you look at the X-ray here, I want all of you to see the X-ray. You can see the aorta is seen. Aorta is calcified. This is all aorta which is seen here. So then we actually did CT angio. Then we did the conventional angiogram showed the subclavian artery is absent. That is completely stenosed and filled by the collaterals from the vertebral system. So this patient, the echo evaluation showed that there is a significant obstruction at the thoraco-abdominal aorta with a severe gradient suggestive of it was an aorta arteritis. So the evaluation done, you can see the angiogram, the first picture, the aorta arteritis, multiple constrictions. You can see the multiple constrictions. The BP which was given was the central arterial BP. So you can see the constrictions. Above the constriction, the blood pressure was more than 200 here, whereas here it is significantly lower, lesser than 110. So this particular patient, there is no role for the medication. You have 1 constriction, 2 constriction, 3 constriction. So this is a typically beaded appearance of the aorta arteritis. Several cases they come. Only thing is we have to look for those. We have to do with the bigger, smaller balloon in the beginning, then bigger balloon. Here, the idea is not to completely abolish the gradient. Here, the idea is to reduce the antihypertensive medications as much as possible. In this particular patient, we had to stent the entire aorta. You can see the balloon expandable stent is given to this particular patient because it's impossible to dilate with the balloon alone without producing a dissection because of the multiple obstructions. So another interesting case of a 13 years old child with Turner syndrome, which was not diagnosed. Only routine evaluation found there was a hypertension, there was a difference. These are the cases which probably cardiologist will dominate and he will put a stent. I am sure that Dr. Neeraj must have done many of these cases with the coarctation of aorta stenting, and which is a routine practice. If the child is more than 25 grams, 25 kilograms, I am sorry for that. I want you to actually see a couple of more cases. I'm sure the time is getting over. Do you have time for another 5 minutes?
Yeah, please go ahead.
Yeah. So this is, you can see that the ECG, nurse recorded high blood pressure. The ECG is like this. You can see the T waves, which are very, very deep. So when you have this kind of deep T wave inversion more than 10, you should always think about a catecholamine induced hypertension. So this baby is having a pheochromocytoma. I'll show you that. In this case, catecholamine excess production causes stimulation of the alpha receptor, vasoconstriction, and hypertension. This child presented with seizures. So operated, this is the operative specimen. And what happens is during the time of surgery, very important to manage. Intensivist should be there, preferably cardiologist also. You have to give the labetalol, phenoxybenzaimine, even nitroglycerin should be given during the time. This is the patient hypothetical graph, which is that. Another 8 years old child presented with abdominal pain and high BP. Any postgraduates can diagnose abdominal pain and BP, came with a headache, vomiting. BP was that. Then we evaluated, we did not find any cause. We did extensive study, labeled as it's idiopathic hypertension. So then we started evaluating urine VMA levels, which are within normal limit, CT abdomen, everything, nephrology opinion, renal workup, extensively normal. But still, he comes once in a while with, and he underwent 2 times laparotomy. This is another patient picture contributed my colleague. And that boy was, we did not put that, they did not agree. That boy was having 2 scars actually. Non-specific mesenteric hidradenitis was present. So again, we re-evaluated. Then urine farfobilinogen was positive, and 24 hours of farfobilinogen levels were significantly elevated, which suggests it was intermittent acute porphyria. So never label as idiopathic. You have to longitudinally also follow that. In porphyria, neurotoxicity increases sympathetic outflow, increased catecholamine, increased vasomotor tone, and hypertension is possible. So some of the cases like this, they present with seizures to the neurology department or general pediatric. They're trying to evaluate. There will be hypertension. They don't find any cause. They see the ECG. Again, there is a significant increase in the T wave here. So we evaluated along with the neurology group, and we found Moya disease. Sometimes Moya disease may be associated with the hypertension because of the vascular constriction. The take-home point is systemic and pulmonary hypertension may be possible in case of Moya disease. Whereas hypertension in neonate, I'll stop with this slide. Thyrotoxicosis, umbilical artery thrombosis, ductus arteriosus. This is one case I want to show very quickly, presented with hypertension. You can see the presented with ventricular dysfunction. Then our nurse found that there was a hypertension, very high levels. Then we actually evaluated her T3 levels. You can see more than 651. TSH was very, very insignificant. Then we took the history. Maternal hypothyroidism was there. Therefore, this baby developed thyroid storm and developed the ventricular dysfunction. In thyroid storm in neonate, maternal goiter, TSH receptors are completely blocked. High T3, free T4 levels will be there, which causes this storm. So I think I will just go the last slide. You have to give the DASH treatment. That is, that dietary modifications for the hypertension, physical activity, stress reduction, weight reduction, and the DASH treatment contains that vegetables, grains, and less amount of sweets and salt foods. So during the clinic, you are expected to recheck everything. If possible, again reevaluate. I would like to summarize that to confirm the diagnosis, classify the hypertension, always evaluate the secondary causes, never label as idiopathic in young children, assess the target amount damage, advise lifestyle modification, and give appropriate treatment for that specific child, for that specific condition, and follow them very properly. Thank you so much for your listening. I think I took more time. I'm sorry, my apology for that.
Wonderful, sir. Thank you. Wonderful talk.
Thank you.
We can invite chairpersons to have comments and then question answers.
Yeah. Thank you, Dr. Nageshwar. for a very, I think, lucid and very elaborate. I think this is a very must for all PGs to listen and attend. I think this is the textbook picture of what classically every PG should know about hypertension and how to manage it and what all to keep in consideration in mind using various drugs. I think the biggest problem with these is that they use drugs left and right without thinking the underlying pathophysiology of the disease. So that is very important, I think. But I think a very good lecture, I think, and I hope this recording would be available to the PGs, Dr. Neeraj.
Yes, yes, sir. Yes.
Yeah,
Yes,
yeah,
yes.
that's great. That's great. Thank you. I have a few query, Dr. Nageshwar.
Sir,
Uh, uh, I think I must congratulate you first for the excellent lecture. And second thing is the way you presented it was absolutely stunning, sir. I think all PGs must have taken down the notes as well because you were so very methodical in presenting each and every drug and each and every aspect of the hypertension. I think it was really amazing. Uh, Hats off, sir. So I
thank
have
you.
a small query. Like we talked about emergent crisis in hypertension. So in that case, in the algorithm you showed nicardipine as one of the drugs.
Yes, sir.
So is that like commonly used drug as first line for these or
Yeah,
IV
actually,
nicardipine available?
adults definitely they are using it, but children we use actually nifedipine as a sublingual medication. You can give any area in the neonate, peripheral, or in the institute in PICU. But in our hospital, we first line medication is sodium nitroprusside. Second line medication is nitroglyceride. Still, there is inter-observal, inter-physician variation is there. Some physicians, they prefer nitroglyceride. Some physicians, they prefer sodium nitroprusside. But Nicardia, sorry for that, nifedipine is the drug of choice.
Okay, right. Do you see cyanide toxicity with nitroprusside?
I have
Do you?
not seen cyanide toxicity, sir. It is a uncommonly used medication because of this same thinking of cyanide toxicity, but excellent medication for hypertensive crisis with especially CNS problem. They come with kind of semi-consciousness and child is not talking, blood pressure is very high, LV function is good. Uh, I think we should go for that. Maybe I will ask Neeraj also to give his opinion on this.
Sir, sodium nitroprusside is the choice of drug in our ICU, in PICU, in cardiac ICU for hypertensive emergency. We have never seen a single cyanotoxicity till now, though you have to take the precaution of covering this with the foil, aluminum foil. But we have stopped worrying about cyanotoxicity nowadays. So SNP is first line drug. Labetalol sometimes we use if it's not controlled by SNP. So we use two drugs for all our post-op cardiac patients or renal patients with the emergency in the ICU.
Sir,
Like
but
this,
I would like to prefer in the periphery setting where the arterial monitoring is not really available. Safer is to start with the nitroglycerine peripheral. Where you have arterial line, you can manage aggressively than nitroglycerine. So nursing homes where arterial line takes time and all those areas, probably nitroglycerine.
So I
I'd like
know
to
Karan
add
is
here
also around.
is,
Dr. Karan, what?
so I'd like to add on like cyanide toxicity is common, especially when you have a renal dysfunction in hand. So we usually keep monitoring in our pediatric ICUs, but in general, it is a pretty safe drug. So it's not like if the renal patient is there, you will not use sodium nitroprusside. So sodium nitroprusside is usually our first choice of agent because it's very well controls the blood pressures. But then you need to keep a check on your cyanide toxicity as well. And usually it happens post 72 hours of SNP usage. But by that time, you're anyways on your oral antihypertensives. So the usage is actually gets down by 72 hours. So
Yeah.
other comments I'll just say, first I'd like to congratulate Dr. Nageshwar for the lovely and the lucid presentation. So for the postgraduates who are there, like just remember one thing, you need to check the BPs first. So most of the time in the heavy OPDs, a lot of times a child's BP is missed. And if you have too much patient load, then better is to train the nurses. As Dr. Rao in his presentation told n number of times, that it was the nurse who told us, nurse who told us. So that's why the nurses training is very important to check the BPs and to have your, you can say the whole set of cuffs that are available, that should be available with you. If any one of the cuff is not available, in times like the adequate cuff is not available, prefer to use a slightly higher cuff than the lower cuff, because bigger cuff will always, like a smaller cuff will always give you a slightly higher BP. So that needs to be again rechecked before you label this child as hypertensive. Secondly, I'll say always treat hypertension as per the pathophysiology. So in case it's a fluid overloaded child, then preferably use diuretics, like a child with post-arterial glomerulonephritis, where fluid overload is the major reason for hypertension. Then diuretics or furosemide comes first. If it's a renin-mediated hypertension or renal disease, parenchymal disease, then definitely ASARBs are your drug of choice. But as sir told, that you have to keep a check on your creatine, you have to keep a check on your potassium as well. So it's not just the creatine. And in case your creatine rises after 72 hours by more than 30%, you're supposed to drop the drug dose by by half. So in case you started with 5 mg once a day of ACE inhibitor, maybe an enalapril, and the creatine rises by more than 30% of the baseline, you can drop it down to 2.5 mg. Just drop it down by 50%. And secondly, in terms of number of drugs to be used, monotherapy versus multi-therapy. So what we use is earlier the you can say the protocol used to be go to the max of one drug and then add the other. So what we usually do in our ICUs is once we are at the 3/4 of the maximum dose, then we use the second drug rather than going to the maximum of one and getting side effects of that drug. We add another drug so that it works in synergy. And the BP controls are much better when you use a combination drug. But then adequately, you're supposed to increase the dosage before you jump onto double drug therapy. And lastly, lifestyle modification is the most important thing. So when the patient comes to you, you're supposed to give him drugs, get the things in order, because most of the time they will be critically sick. But lifestyle modification is the key. Unless that is taken care of, you will just keep on adding drugs to it.
That's a really great comments. And probably with the interest of people, can you please give your preferred choice of medications, Dr. Kanav, monotherapy? I'm sure you will give us a very good idea about that.
So first, monotherapy, like again, I told you, if it's a fluid overload is a major reason for hypertension, we use diuretics. Safely, we use our like calcium channel blockers, which is one of the very safe alternative. So that is our preferred choice when it comes to using the drugs. So calcium channel blockers first, followed by beta blockers. But then you'll have to keep a check whether the child is on a background asthmatic or not, and whether he has pulmonary edema or not. Because if you use beta blocker in a child with pulmonary edema or asthma, he will have respiratory discomfort. And ASARBs depending on the condition of the child. Like if that's a renal parenchymal disease, which is causing the hypertension, and there's no rise of creatinine. If GFR is more than 30 and hyperkalemia is not an issue, then ACRBs are used. And this, you can say the side effect increases double fold in case you use a ACRB combination. So for us, it is a calcium channel blocker first, followed by beta blockers, and then your ACRBs, and then is the alpha blockers like prazosin.
Yes. Thank you, Dr. Kanav. Thank you. Sir, one thing for Dr. Nageshwar Rao, sir. My thing. No, we should have some syrup forms also. And as you're taken initiative for the device, you should take an initiative for the syrup form also. We should have some form of syrup of ACE inhibitors for the infants.
Yeah, that is a wonderful thing. Actually, we attempted to produce 3 syrups. We are successful only one. When I joined here in Hyderabad as a pediatric cardiologist, there was Lasix tablet and Lasix ampoules. To give diuretics, we were either breaking the ampoule, take that and give to the baby. Even some gauze particles will be there, glass particle, or melt that tablet and give that. So we took a lot of time. We wrote a letter to Samrat Pharma when they met a country manager. That the only company actually accepted and produced furosemide suspension. We inquired why people are not producing the suspension. The answer is very simple. The financial aspect, the uh, amount of the number of samples which is being used in the country for this purpose is very, very less. So business policy wise, it is not viable for the pharma industry to produce that. So similarly, captable suspension we requested. They produced experimentally. We got from Dubai, Saudi Arabia, widely available aldactone, spironolactone, and captopril. We started importing, but the government put a brake that you cannot import those medications from other countries. So therefore, none of the companies, because the their interest is less, financial returns are very low. None of the companies are really interested in producing this.
Even
Yes,
I
sir.
had spoken to a few companies for making amlodipine and enalapril syrups, but the feedback which I got over the period of 10 years that it was not very stable. So since the tablets are there which can easily be dissolved, so everybody prefers using the tablets rather than using syrups because of the stability part. Yeah.
What some of the pharmacies in various hospitals, especially government hospitals, have been done is that they're dissolving it in a particular solvent and making it small allocates, and then they can be given, and they have used it in that way.
Yes, sir. The clinical pharmacist can actually
Yeah.
prepare with the stable solution, strawberry syrup or raspberry
Yes.
syrup, they can give that. But the shelf life, as you rightly said, it will work for few weeks to maybe couple of months. That is possible. I think we should adapt that system that the especially spironolactone, lot of children they spit it out. And captopril, unfortunately, which is not available, we are forced to use enalapril, which causes a rise in serum creatinine. Captopril advantage is you can stop it, whereas enalapril, the effect is going to persist for
Longer.
quite a long time. That's the reason. Unfortunately, luckily, at least hydrogen is available. We are making that suspensions or tablets. That's a very wonderful point concern raised by Neeraj.
So the problem with hydrolysine is it has a lot of varied results. So at times the BPs shoot down or something like it doesn't follow a particular trend.
Absolutely correct.
Yeah.
That's the major disadvantage.
Major disadvantage. Yeah.
All the panelists, there is one question. When to go ahead, like when to think of second line investigation. Like if you come, obese child comes to my OPD, I say hypertension, I start the anti-hypertensive drug, single drug. Should I investigate everything? Like I go for renal Doppler in one go, I go to CT scan, everything, rule out porphyria, rule out pheochromocytoma, CT abdomen. So when do I think that this is a I have to go for further investigations? How do you decide in first visit?
Uh, who should answer, Neeraj?
Dr. Nageshwar,
Sir, who should answer
yeah,
the question?
I
Should I
think you
answer?
should start first because
Yeah, I think that is a wonderful point. Partly I discussed in my talk. So after evaluation, history, whatever it is, only first line tests which includes CBP, serum creatinine, and urine analysis and ultrasound. These are the first line steps apart from the ECG and echocardiogram. Once you do that, you will get some clues. You should start medication unless you are strongly suspecting pheochromocytoma or porphyria. If you are strongly suspecting pheochromocytoma, porphyria with gross LVH in pheochromocytoma or intermittent abdominal pain, you should not start any medication. You should straight away jump to those lines of investigation because you will have serious false positives with all these medications in that. So first line medications, if refractory, if there is a target organ damage is present, that is very important. Consult a nephrologist and check the LVH. LVH will give you a somewhat idea that this hypertension is more than 6 months old. So if the LV mass is more than 115 grams, if ECG is showing LVH, target organ is involved, more than one target, I think you have to straight away go to second line investigations. If already patient evaluated second line investigation, coming for second opinion or refractoriness, I don't hesitate to send them for the CT scan, angio or MRI, MR angio based on the renal functions. So I think this is one approach. Maybe
Yes,
I
sir.
would like to listen from other panelists also.
Yeah, Dr.
Dr.
Nageshwar.
Hmm.
Yeah.
So as Dr.
Dr.
Neeraj, you said like an obese child comes with hypertension. So as we know, obesity itself is a risk factor for hypertension. But then the bug should not stop there only. That's just obese. That's why hypertension is there. Because if you can find a treatable cause of hypertension as per the, like, because if you can identify a disease and that can be managed. So it's the time when you can manage it. Otherwise, it just gets labeled as an obese child with hypertension without doing the second line investigation, which maybe 5 years down the line he comes to know because of his, you can say, the other systemic manifestation that he has this disease also. So it's always better that you completely evaluate him on the first go, maybe first line investigation first and then maybe the second line, but do not let this kid go without a complete thorough evaluation. Because nowadays, because of the sedentary lifestyle, a lot of kids get obese. So we should not just stop it there. Because I'll tell you a small example. There was a child who came with hypertension and obesity. Already, like just managed with two antihypertensives for the last 1 year by a colleague of ours, and just came in for a second opinion from the kidneys perspective. Because recently they noted that there is an proteinuria, what is there, and that too associated with fever. So we just followed up the patient that once the fever settled down, whether the proteinuria settled down or not. But then he had a significant proteinuria which increased. Eventually, we also could not find a specific reason and had to go with the biopsy. And there it revealed focal segmental glomerular sclerosis. And this is secondary to obesity. So if you do not pick these things up in time, eventually he goes into a kidney failure like stage, a CKD, and then you do not know what caused what, whether it was a CKD which caused the hypertension or the hypertension caused the CKD. So a thorough evaluation of these children are mandatory. So had we stopped it at that mild proteinuria, there should disappear with fever. So we would have actually missed it off another 1 year down the line. We ventured, like we would have come with high serum creatine, which eventually would have been labeled secondary to the ACE inhibitors.
Yeah. Yes,
I
totally
think
agree.
the carry on thing, I think, is that once we start initial investigation, especially the first line, we'll get some clues that which direction we should probably progress. And I think we should now go with specific investigations rather than treating them or investigating blanketly. And then we can shortlist that these are the important investigations for a particular disease. Yeah. So I think an important thing is clinical examination is very important from a PG's perspective. Just like Dr. Nageshwar once highlighted, we had a similar case. The child came into our emergency. The resident went there, checked the pulse, found there is no pulse, bolus. One bolus, there is no pulse, again second bolus. So without checking into the other side pulses, because that child probably had the resident failed to really look for pulses on the other side, and that child actually didn't had shock or hypoperfusion. In fact, he was having contrary to be having a BP on the higher side, and the child finally had aortoarteritis. But I think simple clinical examinations can give you very important clues at times.
Okay, Dr. Pankaj sir.
Thank you so much. I think I was listening to all the discussion. We already little late. I'll just add 2-3 things from neonatal point of view. One observation which I have done in neonatology of last 30 years of my practice, that in neonatology, transient hypertension is also very common. We see any sick baby who has infection, is on ventilator, is on HFOs and all. They get transient hypertension. You need that. You treat that. You investigate. You find nothing. You keep on treating. After a few days, week, 10 days, they become all right, and then they never come back with hypertension. Number one. Number two, I've seen that preterm babies who with bronchopulmonary dysplasia, you have to actively look for hypertension because they
after 36, 38 weeks, they start getting hypertension, which will be contributing to their disease morbidity also. They're not coming out of oxygen support, respirator. So apart from pH, which is common in BPD patients, hypertension is a common thing. We should look for that. Caffeine therapy is an innocuous therapy, does not have hypertension as a side effect. But if you say overall, caffeine usage is so much. So even if hypertension is there in 1% or 2% of babies who are on caffeine, you will find that 1 or 2 patients in your practice which have hypertension. You cut down the dose of caffeine, and they do all right. So umbilical arterial cannulation or thrombosis is commonly causes hypertension. That also has to be looked into always. And as we always say that the ACE inhibitors, which are very commonly used in pediatric practice, is not to be used in newborns because they disturb the nephrogenesis. Until 44 weeks, we don't use any ACE inhibitors. So these neonatal pulse, it's my pleasant duty as president of IIP Delhi to thank Dr. Nageshwar for an excellent talk today. And also, this is we had excellent sessions, 12 sessions we are finishing today. All sessions will be available on the YouTube of IIP Delhi. So I will say that keep on looking for these videos, these YouTube connections, because ultimately there are so many things which are taught by experts, and you need to listen to them again and again to come to sound understanding of all these issues. So last but not the least, we will be having our next e-master class on pulse in pediatric practice from pediatric ICU perspective, which will take some time. We are going to take a break for some weeks because we're in the middle of our annual conference, which is PCNI clubbed with Norjon Pedicon, which we are doing on 30th and 31st of August. So I request all of you who are attending today to also register, participate in that conference, and also viewers to participate. We will be pediatric intensive care.
Dr. Pankaj, your voice is not audible.
Will be looking forward to see you again in the. I'll stop and I ask Dr. Shamina to say a few words. Dr. Sham.
Hello, sir. First of all, I would like to congratulate our today's speaker, Dr. Rao. Really, IIP Delhi State feeling that so proud on you. You did the wonderful job. And I think our residents really are the lucky to join your today's session. So, sir, you did the wonderful job on your task. Definitely, you nicely cover the whole areas. I'm feeling like during my undergraduateship, I got the opportunity to listen such lectures. You nicely explain the pathophysiology of the hypertension, how the biological clocks work and contribute in the pathophysiology of the hypertension. Definitely, sir, you did the wonderful job. And regarding I have the one small query, because in your presentation, you said the stage 1 investigation, you included the CBC, but you are not included the urine analysis. I hope Kanav is also agree. Urine analysis also as a stage 1 investigation, definitely. Even I can say the ultrasound Doppler is also like the level 1 investigation rather than level 2. So that I feel ki urine investigation should become as a stage 1 investigation rather than stage 2. That I think that
I totally agree with you, sir. I totally agree with you. Even though I put it like that, but we go stage 1 investigation, urine analysis, and ultrasound.
And my small message to all my resident and participant, because I am working in the big tertiary care hospital, in the Safdarjung hospital, there will be a lot of the referral cases we getting. I request you all pre-referral treatment. Those are the children have the hypertensive crisis. Don't hurry to push the patient to higher center. First, give the pre-referral treatment in the form of sublingual. That is very important. Many times child got the intracranial hypertension, other the complication before reaching to our hospitals. So that is also very important thing, the pre-referral treatment, especially in the crisis phase before refer to tertiary care hospital. That is important thing.
Thank you, sir. Can we conclude the session now? Dr. Meena
Yeah,
sir,
yeah.
can you conclude?
Yes,
Okay.
Please.
Thank you so much. Thank you, everybody.
Okay, thank you.
Thank you,
Thank
sir.
you,
Thank you,
sir.
Rajendra
Thank
sir.
you.
Thank
See
you.
you in PCNI soon. Thank you.
Thank you, Dr. Neeraj.
Bye bye. Thank
Bye.
you.
Thank you,
Okay,
Dr. Pankaj.
bye.
Bye, Kanav.
Bye-bye. See you.